across the golf course. How are you, George?
You're muted, George. There he goes.
Yeah. Okay. I'm upstairs, so I can't make too much noise. So that's why I hadn't said anything. I'm waiting on my biscuit to get ready.
Are any of you guys baseball fans?
College.
I thought it was a calamity yesterday that Ortiz got into
Yeah.
the Hall of Fame
Oh
and
my
Bonds
God.
and Clemens didn't.
That is so crazy. That is absolutely crazy. Ortiz, I mean, what did he do to be special about
Well, no, he had the numbers, but he was also somewhat tied to the PED timeframe
yeah.
for which they're keeping Clemens
Yeah,
and Bonds out.
What's sauce for the goose is sauce for the gander, you know. I that's what I couldn't understand. The Rocket, I mean, he really deserves it.
Well, he and Bonds too. I mean,
Yeah.
You know, even if both of them did take PEDs, they did it for maybe a year or two.
Yeah, exactly.
They had 20-year careers.
That's right. That's right. Sports writers are a fickle bunch.
That's for sure.
But, you know, whenever you have a name like Big Papi.
Like what? Oh, Big Papi.
Big Papi. You know, you tend to stick in people's mind. Oh, we can't keep Big Papi out.
He's one of only 4 players to hit 500 home runs and win 3 World Series. So
yeah. But again, all 3 of them were right there at the top. I mean, how can you just say one makes it?
I think Jay is saying something, but we can't hear him.
Jay, we can't hear you.
You're muted to us. His icon's muted.
Jay, Jay, can you hear us? Guess not.
I just said something in the text, so maybe Terry will see that.
Yeah, somebody did.
Yeah.
Well, they may have heard, but they.
Yeah, I would have swore I saw Terry step up into that driver's seat to do something. Unable to hear.
Hear me too.
No, they keep hearing
Oh,
us.
they can't hear us.
All right.
Now we can hear you,
Any
Jay.
guests online today?
No, but we can hear you now.
Well, that's good. All right.
He pushed a secret button.
And the one that says turn on the audio. All right. All right. So final announcement on this one. We have no club meeting next week, but we do have the charter night event. So that's the 3rd on Thursday. We've got a sign up sheet here as well. So if you are able to come, please, and you have not RSVP'd, please let us know. I think we're probably expecting a couple more people that have already RSVP'd. So let's take care of that today. It'll be a Boulder Country Club. We're doing our Spark Plug Award. We have our acceptee is coming, so that'll be good. And we've got some pretty interesting fundraising going on with all of that. I just got a glimpse of it last night, so excited to do that. But yeah, if you are not here today in person, please email Maribeth so that we can have the RSVP completed. We would love to know who's coming, and if you don't RSVP, you're not going to get to come.
No, you get to come, you just can't eat.
I don't know. You get to sit outside in the cold. Watch through the windows. All right, so our big club effort today will be our voting. So we split it up today between the executive board and then the board of directors, just to make it a little bit easier. So we have two ways to vote. We can have a motion per member, or we can do the motion to adopt the ballot as is. So we'll have people online get to vote as well. And I think that at this point, we don't have anyone running contested, so it makes it a little bit easier. It doesn't mean to send anyone out of the room. It's not like that this time. So with that said, I'm opening the floor to motions.
I'll make the motion that we vote the ballot.
Oh, well, thank you. You have a second. Oh my gosh, Amy seconded it. It's on video. It's good for it. All right. At this point, you have three options. You can vote in favor of this motion, you can vote in opposition of it, or you can abstain. And you have to be a club member. So the only people who came to our program and are Howard, our guest. So at this point, we'll take a vote in favor of this motion. All in favor of the executive board ballot as posted, say aye and maybe raise your hand.
Aye.
All right.
I can't tell. Do I just-
Online, I see Dave, and
Dave.
if you could go do a thumbs up on the participant list, also that'd be super helpful for Terry. Okay, all opposed? Oh wow, it's quiet on this end. Anyone opposed online? Val's opposed, it looks like. Okay. And then all who abstained. Anyone abstaining from voting? So they don't want to make a decision. Maybe Val as well. Okay. All right. Well, with that, I think that we passed with pretty close to unanimous favor here. So we'll move forward. Congratulations, everyone. The executive board task.
Thank you, Leslie.
Carrie as well. Oh my gosh.
I gotta get to bed earlier.
All right. Our second ballot for the day is our board of directors. We again have the same options here. So we have mostly second years. So that'd be Tim, Angie, Joe, and Ann are all second year directors in this upcoming Rotary year. And then Suzanne Ginger, Amy Long, and Jonathan Stringfellow will be first year directors for the club. So at this point, we have any motion? Oh,
I'll move to adopt the board of directors ballot as is.
thank you,
I
Joe.
second that.
All right, we've got a second from Bob. Perfect. It's been so recorded. At this point, we'll go ahead with our vote. All in favor of adopting?
Aye.
Right, I gotta see thumbs up.
Oh, I see lots of thumbs
Lots of
online.
thumbs up.
Oh, wow. Val's even on board with this one. All right, all opposed. I got no one here. Anyone opposed over
Oh,
there?
Bob's finally online. He's finally,
Okay, Bob's opposed.
Bob's okay.
Oh, he's saying okay. All right. And then no one abstains online or here. Has everyone voted? All right, cool. Well, at that point, this ballot is so adopted as well. So congratulations, everyone. And thank you for all of our new board of directors for next year. Wow, that was fun. It was way too easy. I thought we were going to have a little bit more. Well, I don't know about this Jay guy. Let's get him off the ballot. All right. With that said, this is the time of the meeting that we go to Happy Bucks. So for those who are unfamiliar, Happy Bucks is the process in which we say something to the club for the good of the club. Maybe something great that happened. Or it could be an announcement or whatnot. And generally that has to go with a little bit of money. So go to this end of the table.
And I'm putting a couple of bucks in because I'm so happy to be back.
Happy for a beautiful day.
I'm happy. It was really anticlimactic. My car turned over 365,000 miles, but it's a digital display, so it was not exciting as watching the ninth roll over.
So money from last week because I was online, so this is for partially for that. It's great to have Maribeth back and Joanne, this is great.
Yes.
While she's having leg surgery today, so keep her, and knee surgery, keep her.
Arthroscopic knee surgery.
Yes, but the big thing I have to tell you, this is so funny, I got up very early in the morning. I'm looking out, there's all these trucks in front of my neighbor's house, and I'm wondering what the heck is going on. They are hosting 17 people in their basement, and they're doing what your mom does, the mitigation.
Oh, cool.
God bless them. So I came home, I thought, gotta bake. So I just started baking and sent up the food on the. Isn't that amazing? Wonderful.
Oh, we've got from our guests.
Yeah, I don't mind. I just want to put happy bucks in. I'm just so proud to see Rotary in action. So after launching the Boulder Rotary Club, it was always great to come and see others participate.
This is a happy dollar because Jim made it through his hernia operation, even though they told him that he may spend the night in the ER because they had no beds. But
Oh, no.
yeah. And the RN wheeled him out in the wheelchair, and he said, "Well, why are you doing this?" She said, "Well, we're short-staffed and we do what we can." And this is a sad dollar because my main shoveler couldn't shovel. And guess who? Shovel.
Yes, healing thoughts from Marsha and for you, and it is so good to see Meredith and Joanne. Yay.
I'm just happy we got the slate of officers for next year. Thank you, Sarah and Dave and Joanne and then on Wednesday I met with a Rotaractor, Andres. And it was that ice storm and he walked out. It was just awful, but we met at Starbucks and he was really terrific and he wanted to set up another meeting. So
Yay.
we're both Western Slope natives. So that was really cool. Except for he was actually born in Mexico. But we still grew up.
Cool. All right, hello everyone. The other side. Lots of happy dollars here for what I owe from Suzanne Ginger, and then for today. Really happy.
Well, I see Terry's got some. I'll just say welcome back, Maribeth and Joanne. Howard, great to have you back, and lots of skiing this weekend.
Well, being kind of the last one, it's a repeat, but welcome back, Mary Beth, Joanne, and Howard. It's great to have you and to have our guest. Oh, there he is. And I'm registered for pets.
Hey,
So
awesome.
here we go.
Anyone online with happy bucks today?
Oh, and thank you for your vote. Yes.
Uh-oh, this is looking a little bit funny. Does anyone online have any happy bucks to share today?
Yes, I have. I have happy bucks and my house was not bothered by the fire, but I finally went to inspect the house at 8 o'clock this morning, so I'll be bailing out. I'm grateful that I was not able to see any soot or damage, but I've got to get an expert in here to see if there is any. And would remember all of our membership that we elected them. Now we got to help them.
Thank you.
Yes, thank you, Bob. Well, good luck today. Any other happy bucks? I see Suzanne Ginger's got her hand up.
Yeah, good morning, everybody. Thank you for allowing me to join the board of directors. And also, I just wanted to say that there are 3 herons visiting with me today. Just a little different than the usual Boulder background.
Oh,
And also, if I could interject quickly, our outreach to other Rotary clubs in the area, we're kind of looking at long-term assistance, but in the interim, everyone, if they're interested, can reach out to the Lafayette Disaster Assistance Center. And if you feel so inclined, That's where the emphasis is short term. And then I think we're all going to step in long term, but that has yet to be determined. Thank you.
Thanks, Suzanne.
Val just wanted to say that he's happy he learned that evidently you don't turn off reactions by clicking again and again.
Well, that's why you voted so many times. George, you got your hand up?
Yes, I'm going to echo what Bob said. We lost 11 houses on our street that were burned up, and I'm thankful for the guy from the sheriff's department or whoever it was that was banging on our door and told us to get the heck out because it's scary. The insurance came by already for us, Bob, and they're going to replace all the attic insulation. They didn't even look at it, and they've paid us very well for the 3 days that we were out. I honestly didn't stay longer because I wanted to get back in my own bed, even though it was 41 degrees in my house. So, Bob, I want to say thank you for reminding me that to be thankful, because that has got to be the scariest experience, one of them, of my life. So happy dollars here. That's it.
Thank you, George. Sorry you had to go through that.
It was just when you're driving down the street, they bang on your door and you say, "Oh, we got to leave," and then you drive down the street and you take a video of the house at the end of the street on fire, which I'll be glad to share with you guys. It's unbelievable, and you don't look for it. You just don't believe, oh, it'll never happen here, but it did. So thanks for all the support too, and the good wishes from everybody. So that's it. Thanks.
We're just glad you're all safe. Any other happy bucks today? All right, seeing no hands or unmuting, we'll move forward. Thank you, everyone. I'm sure that was a very fruitful one. It looked like the cup was overflowing.
Jay, I don't know if you're going to mention it, but there is a gun in a day on February 12th, Saturday, at the community church in Niwot. It's already closed. They got always closed. I'm signed up from 8 to 10.
Okay.
But
was that the email that went out? I think.
yes,
Yeah, that's
yes,
how that
yeah,
went through.
because that's a
They went
good
through the whole list.
I can't do the renovation stuff. I wish I could. But anyway, we can help. I think it's good. So,
yeah, keep an eye out for those email opportunities as club members start forwarding through. They'll, lots of opportunities to get involved. So thank you for reminding us of that. Well, with that said, we're getting very close. I think we could go to the program and then have a little bit extra time for questions, if that's all right with everyone. Perfect. Well, today I'll have to pull out my my introduction email that was sent to me. Bill wasn't able to make it. There we go. What a good photo, right? All right. Well, today our speaker, Michael McHale, is the president and CEO of TRU Community Care. McHale provides executive leadership for TRU's team of over 300 professionals, as well as directs the organization's advancement and strategic initiatives. During his tenure as CEO, McHale has been influential in helping the organization to grow its programs and services in hospice, palliative care, home health, telecare, assisted living, and PACE. TRU serves over 900 individuals and their families each day in the greater North Metro Denver, Colorado community. He's held various leadership positions with hospice in California, Michigan, George, there you go, Maryland, and Illinois, home of Rotary, prior to joining TRU Community Care. McHale holds a Master's of Healthcare Administration from National University in San Diego and a BS in Political Science from Georgia State University. Is that right, Georgia State?
Georgia State.
Oh, well, it was written George, apologize. That said, everyone, if we could welcome Michael.
I think that picture was like 10 years ago, so whoever found that, thank you for back in town. I want to start this morning by thanking all of you I think that Rotary represents all that is good in the world. The fact that you step forward and participate is just incredible. So I want to thank you for being a part of the Rotary family. I will see you shortly in Pets. I'm one of the District 5450 trainers, so
And Leslie.
we'll see all of you there. And also, you know, the early morning reminds me of why I joined an afternoon club.
I wish I did, but I like these people too much.
So that's great. That's great. It is all about friendship, right? You know, nonprofit organizations are technically owned by the community, right? We're given 501c3 status. It gives us tax exemption, and we're given that to address challenges that are facing our community. And there's a plethora of different nonprofits that serve our community that make up that social safety net that we create for the communities that we serve. We're sitting in the midst of one right here that does an incredible job in addressing needs in our community. As a community asset, we're governed by community representatives, which are our board of directors that oversee the asset, and they are challenged and charged with ensuring that we're meeting needs in our community. That's how we maintain our nonprofit status. TRU is no different. If we could go to the next slide, I think it's just the down arrow button there. A little bit about TRU as an organization. So TRU started as Hospice of Boulder County back in 1976. We were started as a social movement to answer the question, is there a better way? And what was happening back in 76, this was a group of folks, doctors and nurses and social workers that at the community hospital in downtown Boulder, saw what was happening as people were facing the end of life, living with terminal diagnoses. They were being admitted to the hospital because of symptoms related to their disease process. They were admitted. We had just developed the new ICU, so we wanted to use all those beds up. We admitted folks into the ICU, and we pretended like we could cure the disease. And we weren't fully addressing the symptoms of what the patient was experiencing related to those disease processes. We admitted them into our ICUs. Many of you probably can remember when ICUs first started, you were only allowed maybe 2 visitors a day for about 10 minutes in the morning, in the afternoon. No kids were allowed into the facility.
Are you clicking it?
I'm not doing anything.
It
You must have
changed.
just got a timer on one of the slides.
So I'm still back at the very first slide.
It's wanting to go the
Oh,
other
it looks like the
direction.
button is crushed in a little bit with the keypad. Yeah, see if we can.
So what this group of folks did was they were really concerned about, gosh, here's somebody who's living with a terminal diagnosis. They're at the end of life. The complexity of the impact of disease has on the human body is showing itself. We're isolating these folks in the ICUs. We're limiting their family intervention with them. And guess what? The individual dies anyways. So this group of concerned citizens here in Boulder said there's got to be a better way for us to do this. And so there was a movement coming across from England called Hospice, and they created the very first hospice in the state of Colorado. And it was probably one of the first 10 hospices in the country. And there was no playbook for this. This wasn't done before in our country. And these folks were trying to figure this out. It was all volunteer organization. There was no reimbursements related to that. In 1983, Hospice of Boulder County was asked to participate in a demonstration program from Medicare to prove out the hospice benefits. So they were one of the very first organizations that proved the financial opportunity in creating a benefit through the Medicare benefit. TRU continued in that light of trying to solve for social issues, understanding that there had to be a better way. The reality, and we'll talk a little bit about this in the presentation, the reality today is what was designed as the Medicare hospice benefit. It's a 6-month prognosis. And back in late 70s, early 80s, from the point of diagnosis to death, 6 months was about enough time, right? But the reality today is we're living longer. We'll talk about that a minute. But TRU realized that if we're really going to impact the community, we've got to really address the complications of the disease process further upstream, not at the point of the end of life, but further upstream. Statistically, on hospice, 30% of our patients who are admitted to hospice die within 7 days, 50% die within 15 days, and then you have the outliers after that. So most individuals don't take full advantage of the hospice benefit as it's presented to itself. PACE is an acronym. It stands for Program of All-Inclusive Care for the Elderly. And in this model, the PACE provider, which is us in this case, is an insurance company and a healthcare provider. So think about Kaiser. Kaiser has their insurance benefit, and then they also have their doctors and their hospitals and their services. So we do the exact same thing. And this was designed back in the 90s. Only about 40,000 Americans participate in the PACE program. But all of your benefit goes to PACE. We have 450 providers in our network, so we provide the care and we cover the cost of the care. And we coordinate everything. It's the best healthcare there is available in this country. The glitch is the 4 criteria for admission. You have to be eligible for Medicare. So you're 55 or older. If you're 55 to 65 and you're eligible for Medicare, it means that you've got a disability, and that's when you're collecting Medicare. You've got to be eligible for Medicaid, so you're income restricted to be eligible for the program. So it's low-income seniors. You have to need assistance with 2 activities of daily living, which is the criteria for nursing home admission. So you're frail, low income, and you need help and support. And the emphasis is to keep you in the community and not institutionalize you into a nursing home. So in the state of Colorado, there's about 5 of us that provide PACE in our communities. As I said, only about 40,000 folks in the country avail themselves of this benefit. The state, it's a collaboration between the state Medicaid system and the CMS Medicare system, and then somebody has to provide those services in the community. It's very expensive to start it up, but as I said, it's the best delivery of healthcare. So we started that in 2017. As you alluded to earlier, today we've got about 986 folks. This morning I saw in the census coming out that we serve in the greater Boulder community. And that includes the services that you see here. So we'll go to the next slide. So as we look around and as we seek to fulfill our mission, we've got to understand what are the challenges that are facing our community. And we have to understand the national trends that are going on. We have to understand the local trends. And then we try to create program and services to meet those needs that are created by those trends that are existing in place. And so the trends that we're looking at is that we're seeing senior population as a percentage of our total rapidly increasing. In the next few years, seniors will surpass the population under the age of 18. Does anybody see a problem with this? Right? Well, you're absolutely right, because who's going to support the tax? Who's paying the taxes to support the benefits that we provide to our seniors? And we don't have enough youth coming in related to that. So we're looking at that trend. We're going to see that flip in early 2030. The next slide shows the demographic distribution in our country. Back in the 1960s, when we designed this Medicare benefit, we had the perfect distribution of population. We had the youngest and the healthiest and the tax-paying folks as the largest percentage of population. We had the sickest and the oldest as the smallest percent of the population. But as the baby boom generation moves through, this is what we're seeing take place right now, where we're going to see that shift, where we have a larger percentage of the population over the age of 65 than under the age of 18. In 2011, we crossed a threshold where 10,000 people a day from 2011 to 2030, 10,000 people a day. January, February, March, April, May, Monday, Tuesday, Wednesday, every day today, 10,000 people in our country will turn 65. And it will happen for 19 years straight. The because it's that baby boom generation. It's us moving through the demographics. What happens when you turn 65? It's your Medicare benefits, right? So if we go to the next slide. Got some good news for you this morning, and I've got some bad news. So I'm going to start with the good news first. The good news, as we alluded to earlier, is that all of our advances in science and technology are helping us to live longer. The bad news is all of our advances in science and technology are helping us to live longer because we've cured nothing. We're only living longer with the impact of the disease process. So if you think about it, we're able to live longer with a cancer diagnosis. And if you're successful to potentially eradicate the cancer, you're living with the debilitating effect of the cure of the chemo or radiation that has an impact on the organs of your body, that may be what ultimately takes your life. If you're diabetic, if you live a long time taking insulin, the impact of insulin in your body on your organs is going to probably be what will take your life. If you have HIV/AIDS, this is a new one for us. It's in our lifetime. It was a disease that immediately was a death sentence. Now we've gotten the science down so well that you can live for a long period of time taking those medications. They're very toxic medications, but we don't know what does the end look like after 40 years of taking those medications. So we're living longer, but we're going to live longer and experience the impact of the aging process and the disease process as we move through our lives. And what this slide shows is not only the fact that we're living longer. So think back in 1965, when the Medicare benefit was designed, average life expectancy at that time was to 72. So the federal government's designing this benefit. They're going, okay, we'll offer it at the age of 65. They're all going to be gone by the age of 72. So it's a 70-year benefit. We've got this young, healthy population coming through. We'll get these people out of the labor force. We'll put the younger people in. They'll pay taxes. It's a beautiful thing, right? Right now, the benefit's on average a 15-year benefit. And as we move forward, it's going to extend even further. So there's a couple of challenges with that. For those of us who've saved for retirement, thinking that we're only going to be around for 10 to 15 years after retirement, we have a nest egg of X. And if we live longer than that nest egg, we're challenged, right? And the reality is, I'm sorry, ladies, good news, bad news for you, is you're going to live longer than us, right? Some bad news that goes along with that. We'll talk about that in just a second. So the next slide, please. And then here's the other reality that we're facing. And these are national statistics, but do you know that Colorado is the second fastest growing state for population over the age of 65, behind Florida. So we're going to see the same movement in our community. The other challenge that we're facing as a society and as a community is the cost of healthcare just keeps going up. Right? If you look at it as an expenditure of our gross domestic product, we spend more than any country in the world on healthcare. Yet our healthcare outcomes are ranked about number 17th in the world. What's interesting is that we spend more. This is the lifespan. And if you want to think about it, this is probably point of diagnosis. And we begin to spend more and more money towards the end of life, with the most money being spent in the last year of life. If you look at it as a piece of the Medicare expenditure, 5%, think about this for just a second. 5% of the Medicare recipients spend 50% of the Medicare budget every year in the last year to 2 years of life. 5% are spending 50% of the budget. It is estimated, I don't like using percentages because I wasn't really good at that, but it is estimated that 40% of this expenditure has no tangible improvement in the quality of life. Just spending money because we have the tools to do things that we want to do. When this graphic came out, the Medicare budget right now is about $775 billion. So think about 5% of the people spending half of that. in the last couple of years of life. So what does that do? What does that mean? Next slide, please. Thank you. If we take an average couple living here in Boulder, looking at all the statistics, so we're going to live longer. All right, that's great. But we're going to live longer with disease and the impact of disease. And the guy statistically will get sick first, right? So if you think of this composite couple that we came up with, Ed and Susan, they live in Boulder County here. They've got a house that they bought way back when, so it's got a lot of value in the house. And that's part of their nest egg for retirement. He will retire at the age of 65. He typically will get sick first with some disease process, whether it's COPD, CHF, any of the cancer diagnoses, he will get sick first statistically. Susan is active in her community. She belongs to the Rotary Club. She belongs to her church. She belongs to various other community organizations. And she will begin to socially isolate herself from her community participation as she's got to stay home more to take care of Ed. Right? Ed and Susan had a nest egg that included that $1 million home that they have here in Boulder. And that nest egg is going to go down and down and down as Ed lives longer with the disease that he's living with. Susan will have to become less involved in church, less involved in whatever, less involved in other activities because Ed can't stay home by himself and they can't fully afford caregiving support in the home around the clock. There's no insurances that pay for them, right? So he will be sick for 2 to 4 years. When we talk about loss, our mission statement at TRU is that we affirm life at every step of the journey with illness and loss. Loss has two connotations. One is the end of life, and we're taking care of the family after that loss. But the other connotation to that loss is what you're losing as you're living longer with that disease process. You're losing your independence, you're losing your ability to drive, you're losing your ability to go to the mall, you're losing your ability to participate in your civic functions, you're losing all of that ability over time. And it has an impact on you as a person and on your loved one. Susan, it has an impact on your family as you're living through this process. So what happens is Ed will die. Susan will now be socially isolated where she thought they had a healthy retirement plan. She is now moved to a lower social economic level. And really the only asset she has is that house. Because in taking care of Ed and taking care of all the insurance costs, Medicare doesn't cover everything. There's co-pays and deductibles and enhanced plans and everything that we have to pay for. She now is at a lower social economic level. And she will live on average 10 years in that state. She has the option to sell the house, but if she does, she can't stay here. Right? She can't afford to do that. She has medical insurance, but if she makes a doctor's appointment, she might not have transportation to get there. Thank goodness we have a great system in VIA, but not everybody can have themselves to that. If she can get to the medical appointment, she might not be able to afford the copay that goes along with it. If she can afford the copay, she might not be able to afford the medication, right? She's going to live for 10 years like this. And in our community, that PACE program that we have, they're the hidden poor in our community. They're here, but you don't see them because they're usually behind the walls of a house that looks like a halfway decent house in our neighborhoods. If you look on 28th Street, the trail of our community, if you look at 80501 along 80503 and 80506, we have large pockets of low-income seniors living there who have insurance, but they can't afford insurance, if that makes sense. They can't afford the cost of health care, right? We had 4 individuals, ladies, on our PACE program. So now we've got this benefit that will take care of some of these folks that are eligible for PACE in our community. But they're typically that 5% of the pie that's using the most of our healthcare costs. Because what happens is when you can't afford either co-pays or medications or transportation, you wait until it becomes a crisis, and then you call 911 and you go to the hospital. And that's your primary care. It's the most expensive primary care that we have in our country, but a lot of people, that's what they have to use because that's all that's available to them to do that. We have for women on our PACE program, this is no value judgment. They were addicted to street drugs. These are older women. These are my mother's age, older women addicted to street drugs. And we had to wean them off of those drugs. And the reason that they had the addiction, it was cheaper to go to the street to get medication, to get drugs, to use as a medication to alleviate pain that they may have been experiencing. Right? Because they couldn't afford the expensive drugs that was being prescribed by their physicians. And so this is the challenge that we're looking at as we look forward into the future as an organization that we have to begin to address, right? So people are living longer. They're going to live long with the debilitating effects. We were talking this morning about somebody living with dementia. Oh my gosh, that disease can go on for 15 years. My mother-in-law has dementia, and TRU, as part of our commitment to the community, we recently bought an assisted living that specializes in dementia. Because we had folks on our PACE program where we couldn't find affordable housing for them to deal with their dementia diagnosis. And so we ended up having to buy a facility because there's no Medicaid beds around to take care of these folks. And if you think about families, so my in-laws, the family came to me and said, well, how much do you guys charge for your assisted living? And I said, it's about $70, $60 a month. Think about it. I couldn't. I don't know about you, but if I'm retired, my income is limited. I don't have $7,500 a month to put I don't have that kind of money to do that. And they thought that that was outrageous. They live in Texas. And I said, so what are you going to do? They said, well, we'll just hire caregivers. I said, okay, that's about $20 an hour. And they go, no, this is Texas. It's only about 15. I go, that's great. Pulled my phone, did the calculator. And I said, that's going to cost you about $19,000 a month. So, which is cheap, right? But those are the options that we have if you can't afford to stay with that person. Susan potentially stayed with her husband the entire time. And she puts her health at risk because she's socially isolated. She needs somebody to come into the home. We talked about that this morning. You all are thinking about offering respite to your friends, so just to be present so that the caregiver can get out of that home. But that's the reality that folks in our community are facing. And again, on that dementia diagnosis, that can go on for years and years and years and years. There is no benefit that's going to cover the cost of that unless you've got some sort of long-term care benefit way back when, but you can't buy it now because it's so far expensive to do that. Next slide. So what we're trying to do is to build an organization that addresses that whole continuum of the aging process, the aging experience. So we know that no longer just a hospice benefit at the end of life is what you're going to need. You're going to need help and support years and years and years before you reach the end of life, because you're living with all the impact and effects of that disease and the aging process in our country. And so we have multiple programs in our organization that begins that walk. I've got them nicely laid out here in a linear process. Nothing follows a linear process when it comes to disease progression. But what we're trying to do is to create a post-acute continuum of care that allows us to begin that walk sooner with folks as we move through the process. My fantasy in my lifetime is I would love to be able to have somebody reach out to us and say, hey, I'm living with COPD or I'm living with diagnosis, and that we can just say, just stand right here, we got you. we'll figure out the right benefit to cover you, and we'll just take care of you from now until whenever that time comes. But unfortunately, our healthcare system is so disjointed that there's not a single benefit that can see you all the way through unless you're on PACE. But very few people qualify for that. It's available to very few people in our country. So we look at post-acute home health services that we provide through TRU Home Care. That's for folks who are being discharged from a hospital. They may have been admitted because of an illness or some impact of some event. And then we have our palliative care program. Palliative care is really specialized care for folks who are living with advancing illness. They're not dying. They're not at the end of the life, but in our disjointed system, you go to the oncologist to treat the cancer, but who's treating the symptoms of the cure and the symptoms of the disease process itself? And that's really where palliative care steps in. It's a specialized group of physicians and nurse practitioners who walk alongside the specialists who's addressing the disease process, and they're addressing the impacts of the disease on the body and life experience, if that makes sense. And then we have PACE, as I explained earlier, the program of all-inclusive care for the elderly. I mean, literally, we cover everything in PACE. We bring our participants, there's 3 components of the PACE program that you have to do. You have to have a day center, so ours is over in Lafayette. You have to have a rehab gym, ours is over in Lafayette, and you have to have a clinic, ours is over in Lafayette. And what happens is you've got these folks, so take Susan as an example. So let's just say she spent down her assets, she now qualifies for PACE, which would be great, a great help and assistance to her. So she's socially isolated. So what we're going to do is we're going to bring Susan, if she wants, into our day center to be with her peers, folks that are in similar situations to her, and we're going to have all kind of activities scheduled for them throughout the day. We partner with VIA. We've made a decision. Most PACE programs own their own transportation operations. We've decided that if another community nonprofit is doing the service and that us contracting with them and giving them money would actually enhance their mission to the community, that's what we're going to do. So instead of us buying a fleet of vehicles, we partner with VIA. And VIA provides all of our transportation. So we provide all transportation to our participants. So they come to our center. We send the VIA van out to their home. We want the driver to go into the home. Don't just sit there. Come on, let's go. I want you to go into the house because we want them to look around the house. Is there a slip hazard? Is there carpeting that's coming untacked? Is there dishes piling up in the sink? Is there laundry that's being backed up because the person's not able to do these things? We want to know this because we're going into it's those social determinants of that. But we want to make sure that we address with the individuals. So the driver goes in. One of the things that the driver does when they get to our day center is they do a handoff with the receptionist at the day center. Hey, when I was walking Susan out to the van, I noticed that she was limping a little bit on her right foot. So the decision's made right there at the front door. We either send her into triage to look at that, why was she limping a little bit, or we send her into the day center for activities. Susan's a diabetic, and so when somebody has diabetes, we work on their feet, right? So she's limping a little bit, so we send her right into triage. The nurse takes a look, she's got a little bit of pressure also that's starting at the bottom of her foot. We want to get that addressed. We want to buy some inserts for her shoes. We want to make sure that we take care of that, because if Susan was living by herself, she would wait until that wound became a serious impediment to her lifestyle, go to the ER, get it addressed, and by that time we could be dealing with gangrene, we could be dealing with other factors related to that. So we're being very proactive because we want to address these issues now to keep her healthy and keep her safe and able to live in her home environment. She goes to day activities, she goes to rehab. If she needs to go to rehab, she goes to the clinic if she needs to go to clinic. So we have that PACE program for the folks who are low income, frail seniors in our community. As I mentioned, we bought landmark memory care for specialized housing. We're very concerned about low income housing for seniors. There's very in this community. Medicare may cover some of it, Medicaid may cover some of it, but most facilities don't offer those benefits because it's not enough. to provide those services. So oftentimes, if we're looking for housing, so if you're on PACE and you need to go to a higher level of care, we're paying for it. If you go to assisted living and you're on PACE, we pay for that assisted living. If you need memory care, we pay for that memory care. If you need skilled nursing, we pay for skilled nursing. But there's often not enough beds available, so we have to send them out to get that. It's weird. I had a really hard time finding Medicaid beds for memory care. So the opportunity came up, but landmark memory care. Then of course we have our legacy program is the hospice program, and then our bereavement support. One of the things that we've started to do is telecare. It's also located in Lafayette. We're going to be moving over to Louisville. We were watching that fire because we had just rented this building in Louisville. And we noticed the bushes were on fire in front of the building, but it didn't get impacted. So we're moving our telecare center over to Louisville because we've had expanded so much. We did a study with Health Impact Lab at the University of Colorado just prior to the pandemic to see how seniors would receive telecare interventions. That study showed us that seniors were open to receiving care that way. And those who didn't like it the most was the provider. Because the challenges of running a system. But then the pandemic hit, and we were fortunately in a position, we were doing a test of 10 devices, right? So you have iPads and you have all these biometrics. We can take your weight at home. We can take your pulse oxygenation. We can take your heart level all from home. Put a device in. It's got peripheral devices that all feeds into a Bluetooth enabled, and it comes back and feeds into our medical record. And we can use that information to help us to determine what we need to do next, right? Because in home health, hospice, it's intermittent care. It's not around the clock care. We're in a couple of days a week, but we need to know what's going on when we're not there. And so this gives us the opportunity to get those readings back. We were testing 10 devices, pandemic hit. And we immediately ramped up to 365 devices because we didn't want to expose people to COVID. We were being told at the time that we couldn't go into the hospital. So if we had a loved one who needed to be admitted out of the hospital to home health or the hospice, coming home, we couldn't go in and admit you because they didn't want us in the building because they were trying to limit the number of people coming into it. So we were able to just put iPads into the hospitals, and they would just move it to a patient's room. And if we were admitting somebody, the nurse in the call center would come onto the iPad. She would explain programs and services. All the required legal documents that you have to sign, we just send 2 DocuSigns to the iPad. We signed it right there, and we're good to go. Right. And so we did the same thing in our nursing homes, but we also extended it so that families could go visit their loved one, either using our hub tent that some of you might have seen in the press that we're taking out to the nursing homes, but they can also then use the technology to Zoom and see their family member conferences or meetings with family members, and then we have to go into the facilities to do that. We're expanding that significantly. Right now, the state has our daycare centers closed down. We worry about depression in this population. If they're socially isolated, you can't see their friends. So all of our classes went online. So you can do booklet, you can do museum tours, you can do bingo, you can do everything through the technology that we're putting into patients' homes so that they can continue to participate. But what's more important, particularly in PACE, is so we can look at you, right? We want to see what's going on. It also tracks and trends your utilization of services. So PACE you used to participate in bingo 3 times a week. You were the bingo queen, you were playing their game. You're only playing once a week. What's going on, right? It gives us the ability to monitor their interaction in the community. So we're expanding that program. We're actually going to be doing a test with a small rural nonprofit hospice in Kansas. And the reason that we're doing this, people on our board of directors said, well, we're going out of our area to make this test. And the reason that we're doing it is nonprofits are a dying breed. If you think of just on the hospice side, it used to be back in the early 80s that 99% of the hospices were nonprofits serving the communities. And now we're about 27% of the hospice providers. So our competition in this area, the majority are for-profits on the state that are paying their investors. And so we believe that we have the generosity of our community and that we can do this test so that we can help those folks in that community to use this technology that they can't afford to put it into their homes. And then we'll measure and monitor that on both dispatch staff out of their local area to support them through telehealth. So this is what we're doing as an organization to try to address these challenges that we're going to be facing more of and more people as we all age in our community. So that's it. Questions I ask?
Hemlock Society. How much information you provide? Do you provide assisted end of life services?
So in Colorado, we have the Medical Aid and Dying Act that came out about a year before I got here. I've been here since 2017. It was launched in the state of Colorado very haphazardly as it was launched. We took a very conservative stance because the majority of our funding comes from Medicare, and the federal government doesn't recognize that law. It's a state law. And so we took a very conservative stance on that. We have since moved to what we call the neutral position, that we're neither a for or against, that it's a law that the patient has the right to choose in this state, and we will honor that choice as that patient chooses that. The challenge with the law is that initially when it started, and we were concerned about this, it was a rich person's way out. Because if you couldn't afford the $5,000 for medication, if you could find a doctor to prescribe it, you weren't available to it. And there's checks in the law that you have to go see a doctor twice. I think you have to talk to them 3 times, but you physically have to see them 3 times or 2 times. And you have to be mentally competent for both those visits. So if you're waiting till the end of life to avail yourself to that option, we had a gentleman at our inpatient care center, which is up at Longmont United Hospital. We cannot allow medical aid in dying because it's a Catholic facility. So the gentleman wanted to avail himself of that. He came to our inpatient center because he had pain and symptoms out of control. He had very complicated cancer with the bones. We had to, it took us a couple of days to get his pain regimen in place. And then he had to back down from the regimen because he was getting loopy from the drugs. So he couldn't go and pass the competency test. So he had to stop taking medications. The pain shot back up, had to check himself out, go to his local doctor he found that would do this, show that he was competent, get that first test passed, come back to our center. We had to amp it back up to the rest of the pain. We had to ramp it back down. So we go to the second one, and then the medication at the time was $5,000, and insurances don't pay for that, so you got to have money in the pocket or a credit card with a limit or enough of a limit on it to get it. So he had somebody go down to Denver to get the medication. He checked himself out. He wanted to die in the mountains. He took a hike with some friends, and he passed before he ever took the drugs. You can't take the drugs back. So it was. It's getting better now. There's networks that are being developed to help support folks to do that. And again, we take a neutral position that we're neither for nor against it, but you have a right as a citizen in the state of Colorado to avail yourself to this, and we will support you through that. That's what we choose to do.
Is there any monitoring organization? I just went through a traumatic event in Wisconsin. My brother died. He was my little brother. He had thousands of dollars of medication. He was low income senior. And we didn't know what to do with it. There was a not-for-profit that took stuff. But why was he ever, it was like he never took them, but he had all these drugs. And it was so much money that was basically thrown in the garbage. It was really unfortunate.
This is practice in hospice. Take all your drugs and flush it down the toilet because there's Mexico that they're very it's becoming bad in the water system. So change the law. Now makes them have technically the drugs out of the ownership family. And there are some places that are set up to receive these back. But you've got to be concerned about expiration date. You've got to be
Well,
concerned-
but there was no monitoring from Medicare saying, wait a minute, why are you giving him a 90-day supply when he hasn't used the last ones? And it was thousands of dollars. I know there's no monitoring.
Correct. And that, that is an example of the point, is that we don't have a system set up. PACE is set up to do that, right? So we are totally involved in the individual's care. We're helping to navigate because we're the payer too. So we're knowing how the drugs are dispensed, how much is being taken, but we're the healthcare provider too. And so is it effective? Do we need to change the medication, right? But there's no national system. Our healthcare is so darn disjointed. And the challenge is, I mean, I feel like I'm pretty savvy in healthcare. I know I work in it. I couldn't navigate the system. Yeah. No, mother in the hospital right now. She had strokes. Families having to be there 24 hours a day because of COVID. There's not enough staff. They're just stretched to the max. We've got a broken system. And there's nobody watching out for anybody else. When we admit folks to PACE, the first thing we do is look at folks. Because the unfortunate thing is, because we're so disjointed, that we had one woman who had 3 cardiologists, and they were all prescribed neurologies, right? But then you've got your cardiologist, you've got your oncologist, you've got your nephrologist, and nobody knows what anybody else is doing. And the first thing that we do in PACE and in hospice is we look at the drugs that you're taking, because 9 out of 10 times, that's what's hastening your demise. It's the counterindication of these drugs that are going on.
My grandmother, 35, 40 years ago, was admitted to the Mayo Clinic in Minnesota. And they discovered that so many doctors were prescribing so many things that were at odds. She lived for another 15 years after that.
Yep.
Because they reevaluated her medications.
We graduated a certain percentage of patients off of hospice because once you put up the drug medication, they actually get better.
Yeah.
The disease doesn't go away, but they actually get better because of all of the interference. We don't have a system that is coordinated and integrated to take care of those.
Yeah.
So that's been my thing. I used to be a chaplain over at Good Samaritan, and I did some clinical pastoral education as a chaplain with TRU years ago. But I thought 10 years ago that we were already on the way to having a system. When you have doctors working for a system, for example, Boulder Community Hospital, that we're all in the same system and they know what my drugs are. And I'm finding out the doctors I'm getting are not connected to Boulder Community Hospital system, even though their office is across the street. So I always thought we were headed that way when your doctors are connected to a hospital, that all those records are available.
We're not. I mean, we're taking steps as a society to move in that direction. What's going to force the change is cost. What Medicare is saying right now, if you look at the Affordable Care Act, the intention of that act was to move us closer to that as a way to drive down cost. And what Medicare basically is saying right now is, we don't know how to fix it. We're just going to drive your cost down and you figure out how to do it. And so that's what's happening right now is the payers are dictating to the providers, we're going to pay you less, but you've got to figure it out. And if you want our money, this is what you have to be accountable to do that. That's why I said that PACE is the best system, because it's one single system. When we send a patient to the oncologist, before we will pay that oncologist, give me those records because I want to see what's going on with this patient. And I want to make sure we put it into our system so that your primary care doc can see what's happening. We only have 250 folks in that program. There's maybe 4,000 people in the state of Colorado that are in this program. That's the most comprehensive system that we have with a payer and provider exception cancer that will look at that. We're slowly moving in that direction. I hope to gosh that I'm eligible for PACE when I need it, because that's who's going to take care of me.
are there any chances at all that PACE will ever be expanded to include those seniors that don't qualify for Medicaid? Because there's a huge need.
Yeah, well, if you think about it, and this is what we're trying to design for. So we have all these programs. Medicare pays for most of these. They don't pay anything for bereavement support. They don't pay enough for everything. But what we're trying to figure out is that exact population. What about Susan in that, profile?
All the ones in the middle.
Right, that just make a few dollars more and don't qualify for it. What happens to them? And so part of what we're trying to use is to use telecare to monitor and be in relationship with them, even though we're not being paid for it, to begin to address those issues. We're seeing them come up through palliative care. We're seeing a little bit coming through home health. There's no comprehensive benefit. We do think that Medicare is moving in that direction to begin to, that's some of the conversation about nationalized healthcare is to look at stuff like that.
Hey, Michael, I'm sorry, we're out of time, but after the meeting, if people have additional questions, would you be available for a few more minutes? Thank you. Well, we really appreciate you coming. This is very informative, both about TRU, but also about the system. I think that's a lot of what you're focusing on here is how there's a lot of need to make the system better. We appreciate learning about that. It's going to help us in our service community. As a token of our appreciation, as a Rotarian, you know how every effort like this is a global effort. What you're doing here impacts everything. So thank God, a mini globe. Thanks so much. That said, it's Wednesday. It's Rotary.
That's during the foundation board.
Foundation board meeting
Right now.
right now.
You already checked.